look at the hepatic veins. Normally, the hepatic veins drain towards the heart. That's why they're registered here in blue, away from the transducer. And on the spectral, they are also registered away, usually below the baseline, towards the transducer where we have systole, diastole, but we have above the baseline when we have the atrial kick. So we have systole, diastole, kick. Systole, diastole, kick. The normal Doppler here, the reason for this pulsatility is because it reflects respiratory phases and variations in central venous pressure that is transmitted from the right atrium. It also reflects the compliance of the liver parenchyma, giving us this triphasic waveform, systole, diastole, kick. Be careful though, because deep inspiration or Valsalva may reduce this pulsatility and dampen it, causing you to think there's a problem. So the waveform becomes abnormal when we lose that triphasic flow. When we lose that, we know that there's elevated right heart pressure. We lose the oscillations or the amplitudes. We can actually lose the atrial kick. We lose that first, and then the whole waveform starts to be more dampened, eventually turning into a monophasic abnormal waveform that is flattened and actually almost resembles a portal vein flow. We call this portalization of hepatic venous flow. So it should be a nice pulsatile pattern, and all of a sudden now it's flow. It's because the liver is stiff, the liver is non-compliant, and does not allow this wave to be reflected in the vessels. So now let's talk about sonographic liver patterns. There are basically three patterns in the liver: the normal pattern, the centrilobular pattern, and the fatty fibrotic pattern. We already discussed the normal pattern. Now there's the centrilobular and the fatty fibrotic. If you look at it closely, this one has too many portal vein walls. This one doesn't have any, and let's talk about the reason for that. In the centrilobular pattern, what happens is the liver is edematous, so that the parenchymal cells, the sinusoids, the hepatic cells become edematous, increase in water, drop their echogenicity, okay? And that makes the portal vein wall stand out, giving it a starry night appearance. So you have these bright walls standing out in a dark background of the night sky. So what we see increased brightness and of the portal vein walls, and we seem to have more portal vein walls. Now the liver does not make more portal veins, it's just that we see them because now we have more contrast. This pattern is seen with acute hepatitis, also seen with acute right heart failure. You may see it with infiltrative diseases of leukemia and lymphoma. We used to see it with toxic shock syndrome, but we don't see that much anymore. And we can see it with 2% of normal cases. And the 2% of normals are usually the young, thin adolescents, maybe 15 to 20 years old. They're so easy to scan and see so well that they look abnormal, and that's easy to tell. The patient is healthy, there's no liver function test abnormalities, so those would be normals. Beyond that, we have to be cautious and rule out liver disease. I would like to bring up fulminant hepatic failure, because this is something that's very serious but could easily be dismissed or misdiagnosed. You will not see this often, but when you see this, you should think of fulminant acute hepatic failure and liver necrosis. What you'll see is areas, patchy areas of decreased echogenicity with prominent portal vein walls, and areas that look normal. They look echogenic, but they're actually normal areas of liver. You look back at these, this is the starry night pattern reflecting acute edema or necrosis, and these are areas of normal or regenerated liver. So they come in patchy areas. This is a case that we recently had of a 22-year-old man who came in with jaundice, and we saw areas of the liver that had increased portal vein brightness, and we thought that that looked like acute hepatitis, yet other areas of his liver seemed to be normal. He did have jaundice, and he was not that sick. However, his bilirubin was close to 30. He eventually got up to 30 in the hospital. And he became so sick that he ended up with a liver transplant. So what happened in this case? It turned out that he was using herbs, certain herbs for bodybuilding, and apparently developed some kind of toxic effect from these herbs, and developed liver failure and ended up with a liver transplant. I have seen such situations happen. One case was a sulfa drug reaction, a woman who was on sulfa drugs for bladder infection, who came in as an outpatient and had this appearance. So we thought that something was very unusual and wrong. We sent her to the emergency room. And after I followed her up in 3 weeks, I found out that she too went into liver failure and had a liver transplant from sulfa drug reaction. Another patient that I had, that I recall with this pattern, was a 34-year-old woman who was weak, a little bit jaundiced, and I thought also outpatient setting, and I thought, gee, this liver, something's very wrong. I sent her to the emergency room, and on follow-up, I found out that within 24 hours she was dead. Autopsy revealed that she went into heart failure. She had lupus myocarditis and lupus hepatitis and developed this acute fulminant failure. So these are unusual cases, nonetheless serious, and we should not dismiss such an appearance. If you're not sure, if it doesn't look like it matches the clinical picture, we should send the patient right away for evaluation. The fatty fibrotic pattern is opposite. We have increased echogenicity of parenchyma. There's some kind of infiltration with fat or fibrosis going on in the liver, which increases the echogenicity high enough that it matches the portal vein walls, and the contrast is lost. Therefore, we do not see the echogenic portal vein walls. In this pattern, we look at the echogenicity, that's increased, but then we have to look now at the echo texture. It could be a smooth, homogeneous echo texture of the parenchyma, or could be heterogeneous or coarse. Sometimes we see sound attenuation, and this type of pattern is usually seen with fatty infiltration, but also seen with chronic hepatitis and cirrhosis. So here's the fatty fibrotic pattern with the homogeneous echo texture. Here's the fatty fibrotic pattern, loss of portal vein walls, with the heterogeneous pattern. Notice we almost see little tiny rounded masses throughout, a little bit nodular. That's what gives it this heterogeneous appearance. Let's look at the fatty liver. Fatty livers are of this pattern, echogenic, loss of portal vein walls. When it's a very pronounced case, there's so much attenuation that we can't even image the hemidiaphragm, as we have in this case. We've tried to increase the TGC curve posteriorly, and we cannot fill in with echoes. Notice how nice and homogeneous this pattern is. Now, fat can do two things focally. We can have focal fatty infiltration, and we can have focal fatty sparing. Okay, here's focal fatty infiltration, where we have areas of fat. Now, the fat part is echogenic. Fat areas of fatty infiltration interdigitating between areas of normal liver parenchyma. And we also can have focal fatty sparing. Here are areas of normal liver, not affected by the fatty infiltration. You look carefully, you see little vessels inside. There's no distortion. This is a completely normal little liver pattern. That's areas of normal liver spared. These can possibly be confused with liver masses. However, they occur in a very typical location around large portal veins, around fissures, and subcapsular. So we tend to look in those regions, and we look for internal architecture and see that it's not distorted. Cirrhosis has this fatty fibrotic pattern. Now, when we make a diagnosis of cirrhosis, we look for heterogeneous echo texture, so coarse sometimes that it looks moth-eaten, and it's from these little islands of regenerated tissue mixed with diseased tissue that causes this heterogeneous pattern. The livers tend to be small and shrunken. They have a nodular surface. Often there's ascites to help us delineate the surface. And these are the livers where we can see the enlarged caudate. So if you see an enlarged caudate to right lobe ratio, and if it's over 0.73, that's a 99% specificity for cirrhosis. It's not sensitive, but it is specific. Here's a cirrhotic liver. Try to imagine what you would see on ultrasound. You see these nodular areas of regeneration all throughout. In between are these fibrotic bands, and that gives this nodular appearance, sometimes micronodular, sometimes the nodules are bigger, and sometimes macronodular appearance. Look at these tiny little islands of regeneration inside the liver, which cause vascular channel disruption, etc. So when we see a cirrhotic liver on ultrasound, we then have to right away look for clues of portal hypertension. So with portal hypertension, the liver is diseased. The liver parenchyma develops resistance to blood flow. This increases the portal venous pressure. Eventually, the portal flow will slow down and it will reverse, and flow will actually be going away from the liver, hepatofugal, and there's then increased risk of bleeding because collateral vessels open up. The ultrasound findings of portal hypertension include ascites, a dilated main portal vein, splenic vein, or spiromesenteric vein. What is a dilated portal vein? Well, a portal vein bigger than 13 millimeters in diameter we consider dilated. A splenic vein or superior mesenteric vein centrally, when it measures more than 10 millimeters, we consider that dilated. So just a simple measurement. We look for collaterals. Splenomegaly is part of it, and various Doppler findings. Where would we look for collaterals? Well, right away, the first place to go is the gastroesophageal junction, GE junction. We then can look for a coronary vein, which would be a little branch off the main portal vein or off of the splenic vein. We would look for a recanalized umbilical vein heading towards the umbilicus. We can have gastrosplenic vessels. We can have a splenorenal collateral. We can have a gastrorenal collateral. We can have perisplenic, all kinds of retroperitoneal collaterals, vessels that we don't usually see suddenly appear. So we try to look for them. On ultrasound, here is the aorta, the gastroesophageal junction, GE junction, and tortuous serpiginous vessels in the region. These would be the gastroesophageal collaterals. Here is a sagittal section through the recanalized umbilical segment, recanalized umbilical vein, and it has flow heading out of the liver towards the umbilicus, hepatofugal flow out of the liver. In this image, we see the splenic vein, which is posterior to the body of the pancreas, and it seems to have a branch. We usually never see a branch there, but when we see such a branch, that's a perfect place for a coronary vein. Here's a spleen with large vessels around it, up in the left upper quadrant. Perhaps these are gastrosplenic collaterals. Here's perigastric or perisplenic kind of collaterals. Here's a large spleen with the left kidney, and there's a large tortuous vessel in between, a splenorenal shunt. What are the Doppler findings in portal hypertension? Well, let's look at the portal veins. First of all, we're going to lose the respiratory variation. The waveform becomes very flattened. We have a drop in the velocity of the main portal vein, and eventually it may reverse and be on the reverse side hepatofugal flow. Hepatic veins. Hepatic veins start to lose their normal pulsatility. We had systole, diastole, kick, systole, diastole, kick, and now all of a sudden it's becoming a very flattened waveform. Hepatic arteries, the only thing we'll see is that they can become quite large. And also notice here on this color image, the hepatic artery is red, the main portal vein is blue. They're opposite colors. The artery and portal vein should be the same color. This means that the artery is going towards the liver and the vein now has hepatofugal flow. So we can see that as two different colors. You can also see enlarged hepatic arteries in the parenchyma of the liver. And what happens in that situation is in the portal triad, where you have the little portal vein, on top of it is dilated a little hepatic artery. Now also sits there the bile duct. Usually when we see a dilated duct on top of the portal vein, we see this parallel channel arrangement. But it can also be seen with a dilated hepatic artery. We turn on Doppler. One has venous flow, one has arterial flow. Now the last segment that I'd like to talk about the liver is regarding liver masses. Ultrasound is excellent in detecting focal liver lesions. We're very specific. We're specific for liver cysts, but liver cysts that are about 1 centimeter or more, because very tiny ones we may not be so sure about. But ultrasound is not good in differentiating among the different pathologic entities. There are very few ultrasound features outside of cysts that are characteristic of the mass itself, the pathology. We are not good in distinguishing between benign and malignant masses. Triple face liver CT and MRI are excellent modalities for this, but we are good for picking up a focal mass, and we are also very helpful in the diagnosis in the proper clinical setting. We're good for follow-up and as a guidance for biopsy. We can see simple cysts. Now this is a classical cyst like anywhere else in the body. Anechoic mass, smooth margins, excellent sound transmission. So this is a simple cyst in the liver. What else can be simple cyst? Well, an old hematoma, a hydatid or echinococcal abscess, which this is. This is a patient from Egypt who had a solitary cyst, and eventually this was diagnosed to be echinococcal. A biloma or a seroma can look like a simple cyst. And if we ever have a vascular structure, or if we ever have a cystic structure that looks unusual, not perfectly round, we should always think of the possibility of this being some type of vascular structure like an aneurysm or some unusual fistula like arterial portal venous fistula or portal to hepatic vein type of a fistula. We can have multiple cystic lesions throughout the liver. Very often these are associated with adult polycystic kidney disease or the dominant polycystic kidney disease. We could see multiple cysts with echinococcosis or hydatid disease, as was in this case. We can have multiple cystic lesions throughout the liver that are actually choledochal cysts, the type 4 and the type 5. Type 4 has the dilated duct, bile duct. Type 5 has a normal bile duct. but we can see these structures, cystic structures throughout the liver. If we look